Hello everyone. Welcome to our video on obsessive compulsive disorder in children and adolescents, also known as OCD. This content is presented by myself, Mia Trupiano, and was written by Courtney Clements. We are both students in the psychiatric mental health nurse practitioner program at Southeastern, Louisiana State University and Nicholls State University, respectively. This presentation has been completed for the fulfillment of our technology integration project. So, we're going to start with a pre-test, and then by the end of it, we'll do a post-test and post the answers. It should be pretty straightforward, and I think you'll learn the basis of OCD, how to diagnose, and its treatment. Question 1 of the pre-test. What is the first-line treatment for OCD in children and adolescents? A. Motivational interviewing. B. CBT. C. Risperidone. 2. What is the driving force behind a compulsion? A. Anxiety. B. Depression. Or C. Psychosis. Question 3. What antidepressants have been shown to be most effective in treating OCD? TCA, MAOIs, or C. SSRIs. 4. What is the final phase in treatment in CBT for OCD? Response prevention, relapse prevention, or C. Psychoeducation. Question 5. When should pharmacology be utilized? Select all that apply. A. If symptoms are severe. B. If treatment with CBT fails. Or C. If CBT is unavailable to the patient. Okay, let's get started. So during the presentation, we utilize the constructivist learning theory. Constructivist learning theory is the idea that every student has a unique perspective, and new knowledge is added or built onto existing knowledge through experiences and interactions with others through conversations and discussions. So in other words, constructivist learning theory is based on the idea that we learn through each other, by absorbing the information ourselves, and through our experiences in the real world, we can apply what we learned and further deepen our understanding. Okay, the learning objectives we would like to achieve from this video are the diagnostic criteria for OCD, to learn when and how to treat OCD with psychotherapy, and to learn when and how to treat OCD with pharmacotherapy. Alright, so let's get started. First of all, what is obsessive compulsive disorder, or OCD? So, double checking things is a pretty typical human behavior. We do it, like, for example, did I lock the front door? Let me double check. Or did I turn off the oven? Let me double check. But what if you feel compelled to triple or quadruple check? What if before you go to bed at night, you have to do a ritual, like unlock and relock the deadbolt 3 times? Turn the porch light on, then off, then on again, then check the lock again. Then that might be a compulsion. Obsessive compulsive disorder is a severe, prevalent, and most often chronically debilitating disorder, characterized by repetitive, ritualistic, and distressing thoughts, ideas, and behaviors over which a person typically has very little, if any, control. Approximately 50% of all cases present in childhood or adolescence. Obsessions and compulsions in children are more likely to change or evolve, as well as wax and wane, compared to the course of disorder in adults. So now let's talk about the diagnostic criteria for obsessive compulsion disorder. The DSM-5 criteria for OCD is the presence of obsessions, compulsions, or both. Let's define obsessions. Obsessions are defined as recurring, persistent, and often unwanted thoughts, urges, or images that cause anxiety or distress. The individual attempts to ignore or suppress the thoughts, urges, or images with some other thought or action, like by performing a compulsion. This action usually reduces the anxiety from the obsession. Now let's define compulsions. Compulsions are defined by repetitive behaviors such as hand washing, checking, or mental acts like praying, counting, or repeating words silently that the individual feels driven to perform in response to an obsession, or according to rules that must be applied rigidly. The behavior or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. However, these behaviors or mental acts either are not connected in a realistic way with what they are designed to neutralize or prevent, or are clearly excessive. In order to meet the diagnosis, the obsessions or compulsions must be time-consuming, take, let's say, more than 1 hour a day, or cause significant distress or impairment in social, occupational, or other important areas of functioning. The obsessive compulsive symptoms cannot be attributable to the physiological effects of a substance, such as drug abuse or a medication, or any other medical condition. The disturbance is not better explained either by the symptoms of another mental disorder. Fun fact, celebrities like David Beckham and Howie Mandel are affected by OCD. So now that we know what OCD is and how to diagnose it, let's talk about how it can be treated. Treatment for OCD in children and adolescents include medications and psychotherapy. A combination of medication and psychotherapy may be useful in cases of more severe comorbid or treatment refractory illnesses. For mild to moderate cases of pediatric OCD, we suggest first-line treatment with CBT, also known as cognitive behavioral therapy. No other psychotherapies in youth have received comparable study, nor have they demonstrated consistent efficacy in clinical trials. An SSRI can be used first-line in cases of patient and family preference, or if cognitive behavioral therapy is not available. So basically, to summarize, first-line treatment for obsessive compulsive disorder could be monotherapy with cognitive behavioral therapy, or monotherapy with SSRI, or it could include them together. Let's talk more about cognitive behavioral therapy, or CBT. CBT can be done in person or over the internet. The in-person program consists of 14-hour long sessions that is completed over a 12-week period with the child and one or more family members. These sessions are also supplemented by 10-minute phone sessions for most weeks. The therapy is typically provided individually, but evidence supports its use in groups and with and without participating family members, and it's understandable why family members would need to be completed if the child is especially young. The clinical effects of CBT can decline over time. Booster sessions may be provided in the months or years following treatment to prevent or reverse the decline. So there's also internet option for CBT. Internet-delivered CBT may be as effective as face-to-face CBT for pediatric treatment of OCD. In most countries, children and adolescents with OCD have limited access to a provided specialist. Internet-delivered treatment may help CBT to reach more individuals by breaking down the barriers to accessibility. So both CBT, cognitive behavioral therapy programs, whether it's internet or in person, are going to consist of 5 phases of treatment. The 5 phases of treatment are completed in this order as follows. First phase, psychoeducation, followed by cognitive training, followed by mapping OCD, followed by graded exposure and response prevention, and lastly, relapse prevention and generalized training. So the first phase, psychoeducation, that basically involves educating the patient and family about what OCD is. What is, teach them what obsessive compulsive disorder is, and you also teach them its causes, help them to know it's not because of poor parenting or, and that there is a genetic component. It can actually put them at ease, and talk to them about treatment options and that there is a good prognosis with treatment. Although it may be a chronic lifelong condition, with treatment, symptoms can be controlled. And then cognitive training. So that could include, working on the thoughts and talking about why I think if I touch this button 3 times, my mom will get home safely, for example, and to really challenge those beliefs. And that is part of cognitive training, is challenging those beliefs in a supportive, collaborative environment. Graded exposure and response prevention. So that is where you gradually increase exposure to things that cause anxiety for the patient, and then you prevent that patient from doing whatever compulsion they would normally do following that event. And then, of course, the last one, relapse prevention and generalization training, is what it sounds like, to help them to prevent and to continue to use what they learned even following the sessions once they're over. Okay, so how effective is cognitive behavioral therapy? So we're going to talk about some research and what it has to say. So in one systematic review and meta-analysis of 9 randomized trials with 645 youth with OCD aged 4 to 18 years, in this study they compared treatment with CBT to a control condition. Compared with control group, patients who received CBT had a greater reduction in OCD symptom severity. Another clinical trial randomly assigned 96 youth aged 10 to 18 to receive CBT, 12 sessions for the group, brief CBT, which consisted of 5 sessions and a therapist-guided workbook, and a waitlist control group. Both patients in both treatment groups experienced reduced OCD symptoms compared to the control group. No significant differences were seen in outcomes between treatment groups. Improvements were maintained at 17-week follow-up. So that's pretty good. Whether they did the brief CBT or the 12 session, they were both showed improvement compared to people who weren't able to or didn't participate in the CBT, and it lasted, as far as they know, at least up to 17 weeks. So, another clinical trial randomly assigned 54 youth aged 7 to 17 who failed to respond to initial course of CBT to receive either 10 additional CBT treatment sessions or treatment with sertraline, also known as Zoloft, which is an SSRI, over 16 weeks. No significant differences were seen in outcomes between treatment groups. However, nearly half of patients in each treatment group, 50% for CBT, 45.4% for sertraline, also known as Zoloft, experienced reduction of OCD symptoms. So basically, that study was showing that both CBT and the medication sertraline showed effectiveness in treatment for OCD. So, and also it showed that for patients, especially with pediatric OCD, even if they initially failed to respond to CBT, additional CBT treatment may still be effective for reducing symptoms. It might take them a little bit longer to work out on these things. It's a learning curve as well as therapy. Okay, so now we're going to talk about pharmacotherapy, so basically medication used for the treatment of OCD. Pharmacotherapy can be utilized in the treatment of OCD if CBT does not work or if the patient's compulsions are too severe and cause too much disruption in life. Again, especially in children, parents may not want to start on medication, so they may try CBT first, but they're both good options, medication or CBT. Selective serotonin reuptake inhibitors are the initial medication of choice for pediatric OCD due to their efficacy, and they are generally well tolerated with little side effects. The most common side effects include headache, abdominal pain, nausea, diarrhea, sleep changes, jitteriness, or agitation, and generally the side effects do resolve after the patient gets used to the medication. SSRIs have also shown to be effective and safe in this population, and some examples of SSRIs used for the treatment of OCD in the pediatric population are fluoxetine, fluvoxamine, and sertraline. All right, so back to some more studies about medication. A 2003 meta-analysis of 12 short-term clinical trials with a total of 1,044 children and adolescents with OCD found serotonergic antidepressants to reduce OCD symptoms compared to placebo. An overall effect size for medication versus placebo was 0.46, equivalent to approximately 4 points on the Children's Yale-Brown Obsessive Compulsive Scale. The Children's Yale-Brown Obsessive Compulsion Scale is a scale often used in research, basically to test the severity of symptoms. In another study, a 12-week clinical trial, randomly assigned 187 children and adolescents aged 13 to 17 years to receive sertraline. The dose that they received was up to 200 milligrams a day, or they received placebo. Patients treated with sertraline showed greater improvement compared to placebo-treated patients in the rate of response. So 42 versus 26. So 42 showed improvement and in reduction of OCD symptoms. So the medication seems to be pretty effective as well and is usually well tolerated. And that medication, again, is an SSRI. Okay, now we're ready for our post-test. I'll let you guys read through that, and then the next slide, we will post the answers. I hope you found this video educational, and good luck. Thank you.